Seizures. These are abnormal. These are periodic episodes.
That's it? Only else?
There are different types of seizures, but the most common type is the tonic-clonic type of seizure. That's the only one we will be testing and discussing today. So it's a combination of abnormal motor, sensory, autonomic, or psychic activity. This is harmful. The patient's brain is deprived of oxygen during the seizure. So therefore, our goal is for that seizure to last no more than a few minutes, okay? No more than 2 minutes. In fact, a seizure lasting 5 minutes or more is fatal. Patient can die, or if they survive, they will have permanent brain damage. Okay. Shortly, we will differentiate between seizure disorders and epilepsy, because they're not the same. Okay. Now, for a seizure to be called a seizure disorder, there has to be an identifiable cause. I repeat, if your seizure occurs with an identifiable cause, then that's all we call it. It's a seizure. All right. Now, it's different in epilepsy, because in epilepsy, the patient has 2 or more seizures with no identifiable cause. That's why the only treatment for epilepsy is or are anti-seizure medication. So if the patient has epilepsy, they may be treated with 2 or more types of seizure medications. Okay. So what do we do instead? If, let's say, your seizure has a known cause, and these are, by the way, the causes. This is the type of seizure. So I guess I already told you that we're only testing the tonic-clonic type. Okay, so we'll skip chart 61-4. These are the known causes of seizures. So if a patient is, well, it's better if the patient's seizure was witnessed, meaning somebody saw the seizure happen. But most of the time, it's not witnessed. Say the patient was sleeping alone, or there was nobody around when it happened. So we will have to do a test. Okay, we'll get to that a little bit later. Now, these are the possible causes of seizures. Allergies, a brain tumor, how does a brain tumor do it? Well, it causes increased intracranial pressure. So therefore, any other condition that does the same, like a cerebrovascular disease, for instance, which is a stroke, or it could also be head injury, or any head trauma, which leads to increased intracranial pressure, can therefore cause seizure. CNS infection, the same, meningitis, for instance, or viral encephalopathies, those things can increase intracranial pressure and therefore trigger a seizure. Drug and alcohol withdrawal. So if someone, let's say, wants to quit cold turkey, that can be dangerous because, let's say, they're a drug user or alcohol, they're alcoholics, and then they just stop drinking. So within 24 hours after their last drink or their last drug use, they could go into withdrawal, and the withdrawal can trigger a seizure. Okay? So it can be dangerous. So if you know any friends, they have to really go to a detox unit. Okay, so if they're serious about quitting, they have to do it safely. Okay, it's not safe to just quit cold turkey. It can be harmful. Fever can also trigger a seizure. So in my first year of life, I had 3 seizures, all caused by a high fever. So my mom said I had 103, 104 seizures as a baby. So each time I had a seizure. Okay, so I don't have epilepsy because, again, what was the trigger for my seizure? Okay, there was a known cause. All right. Yes, Lewis?
Chart you said, 61-4.
Yeah, the type of seizures, we don't discuss that because again, we're only discussing one type, which is the tonic-clonic type. So I mentioned head injury already. Hypertension, this is severe hypertension, okay? So blood pressures of 200 systolic over 110 diastolic can also cause a seizure because blood pressures like that increase ICP. So same mechanism as the other causes such as infections or stroke or head injury. Hypoxemia. Yeah, over 200 systolic, over 110 diastolic. So for hypoxemia of any cause, so that could be from an asthma attack or let's say any brain anoxia. So let's say someone has a cardiac arrest. We were unable to perform effective chest compression. So that causes hypoxia. It can lead to a seizure. And metabolic conditions, let's say we've discussed DKA, correct? So in DKA, wherein there was severe metabolic acidosis or any other condition, let's say shock also, severe lactic acidosis, your lactate levels are sky high, so you're in an acidotic state, yeah? So therefore, that can also trigger a seizure.
What about the stroke?
Yes, a stroke can cause a seizure. Doesn't matter which one, whether it's ischemic or hemorrhagic stroke.
So what if they become acidotic from respiratory distress?
Yeah, any hypoxia of any cause, okay? Because hypoxia causes what type of imbalance? Respiratory acidosis, right? Okay, again, and not any metabolic disorder causes either, especially if it causes acidosis. So manifestations. So I said we're only testing the tonic-clonic type. So this is the pattern. Now, not all, but most people experience with when they have a seizure, especially if it's epilepsy. However, if it's a seizure disorder, they may not have an aura, but people with epilepsy, which is on the next page, have an aura, meaning they can tell when they're about to have a seizure. However, when the seizure subsides, they have no recollection of what happened. They just assume that they have a seizure, okay? Again, if it's epilepsy. So there are many auras, but most people with tonic-clonic type experience the following. So they'll have some shaking, then their muscles become stiff, okay? They have muscle rigidity, and then that's the tonic phase, meaning all muscles become rigid. And then this will be followed by clonic activity, which is the jerking movements of the muscles. So it's an alternating, so the clonic type, which follows the clonic phase, which follows the tonic phase, is now alternating muscle relaxation and contraction. Okay, but the first phase would, of course, be the rigidity. So the tonic phase first. So all of these can happen. So the patient may bite their tongue. They could experience bowel or bladder incontinence or both. And then there's the post-ictal phase. Now, the post-ictal phase is the exhaustion phase, meaning this period of the seizure activity consumes a lot of energy. Okay, plus it's very harmful to, like I said, the brain. It causes brain anoxia. So therefore, the patient is tired after that. So they'll rest. We don't know. Sometimes the rest can only be, the post-ictal phase can only be 30 minutes, but it could be as long as 8 hours or even longer than 8 hours. Okay, so the patient will be sleeping at that time. Unless, of course, they sustain injuries, then we have other problems. By sustaining injuries, I mean, what if the seizure happened in the subway tracks? Okay, so let's say you were up at the platform just waiting right behind the yellow line, and you fell, you had a seizure, and then you fell into the tracks, then there'll be no post-ictal phase. Okay, so how do we know you had a seizure? The doctor will order an EEG, that's electroencephalogram. So it's a test wherein they put 1 million electrodes on your head, register electrical brain activity. So if there's increased or overactive brain activity, then that means you just have recently experienced a seizure. Okay. Doesn't have to be taken right after the seizure. Okay, as long as it's done within 24 hours of the suspected seizure. So there will be some increased brain activity, increased electrical brain activity. An MRI would help rule out other causes. So let's say it can help us see, okay, do you have meningitis? Do you have did you have a stroke? Do you have a tumor there? Okay, so we investigate what triggered the seizure. Now, if none of these come back, we did blood work. Okay, we looked at your pH, for instance. There's no drug or alcohol in your system, for instance. So therefore, we did all the tests. You're clear, but you had a seizure. If it happens again, then you will be diagnosed with epilepsy. All right, so let's do what are your responsibilities? So if the patient has a seizure, and this will be, of course, a select all that apply question. Okay. So these are your assessments. So what happened before? Because we need to know what type of seizure the patient had, or whether it is a seizure or if it is epilepsy. Okay. Now, the important thing to note is if it's witnessed, we need to know what time did the seizure start. Why do we need to know the time? Okay, we need to know the duration. How long did the seizure last? Okay, so like I said, if the seizure lasts 5 minutes or more, or if the patient experiences multiple seizures within 30 minutes of one another, then that's still called status epilepticus, which again is life-threatening. A patient could die. So you note all of these, okay, if someone saw it, or let's say you were firsthand, you were the witness. So you note all of these, okay? So you note whether they had foaming at the mouth, whether they bit something, or what type of injury was sustained during the seizure. So what we do during the seizure is just keep the patient safe. Do not restrain the movements. There's a chart actually. We'll get to that shortly. Just keep them from injury. So let's say it happened at the subway platform. So what do? They're about to fall off the tracks. Okay? But the textbook said do not restrain the movement. So you just allow them to fall. Okay? Oh, he fell down. Okay? No, of course you try to keep them safe. But what I mean is do not restrain. If they're jerking like this, then do not hold it down. Okay, so just keep them safe. Or let's say they're doing this and then they're doing this on the concrete. So what do? Okay, put something underneath their head. Okay, that's all you do. But do not restrain the movement because you will cause further injury if you restrain the movement. After the seizure, like I said, the patient is exhausted. So let them rest. Put them in a sideline position because you don't want them, because they have no control. Okay, these patients are unconscious. So therefore, they may aspirate during the post-ictal phase. So these are your concerns. It's really the aspiration and other injuries that they may sustain. All right, so if the patient has 2 or more seizures with no identifiable cause, then the patient will be diagnosed with epilepsy. Okay. So there's a lot of people have epilepsy. Just go to a nursing home and you'll see several. Those at home, then we'll never know because they're at home. Pathophysiology, because again, this has no known cause. We don't know the specific trigger. Some patients will have auras, like I said. Auras will be the pre-seizure, sensory motor manifestations that they'll experience. So here's the chart I was referring to earlier. So these are your responsibilities during a seizure, I'll let you read these. Now, take note, we do not put anything into the patient's mouth now. We stopped doing that in the 1990s. In the 80s, though, we had a padded tongue blade at the bedside. So that's what we put. We put a tongue blade with gauze in it. We put it in the mouth because we believe, that will help them from losing teeth. But we discovered later, as they happened, that the patient was choking, okay, because they bit off the padded tongue blade and then they aspirated, it obstructed the airway. So best practice now is stop doing that. Okay. Yes.
Hospital, said, I don't know if it's in this one, but if a patient is having a seizure, you don't automatically call a rapid response, so you have to wait.
You can, yeah, you can, because what if it's status epilepticus? Okay, so we need orders to stop the seizure.
If it's like the first chance, like you walk in and you see like they're.
Yeah, regardless, you call rapid response. Yeah. Because again, we don't know, because you can't like wait, oh, it's not 5 minutes yet. Okay. All right. Yeah, does that make sense? Okay. Plus, we don't really allow the patient to finish. If the patient's actively having a seizure, the doctor will order a benzo. Okay, so we'll use either lorazepam or diazepam. We have to terminate the seizure because they're in a hospital, so there's no reason why we can't terminate it. Make sense? It's different at home. I mean, who carries IV Ativan or IV diazepam at home, eh? Maybe if you have a stash, but again, we can't, can't expect that to happen. Then afterwards, so we already discussed, this is what you do afterwards, okay? Keep them safe, put them in a recovery position. All right, so let's look at our equipment. So if the patient has order for seizure precautions, so what are the possible causes of a seizure again? So we had those several bullets listed, right? So therefore, if a patient is here for drug and alcohol withdrawal, what do? Do we institute? Yeah, so they're at risk for seizures. What about if they had just had a stroke?
Yeah.
Or they're here for head injury? Okay, or let's say they have severe, azotemia, those patients that miss a dialysis, for instance. Okay, or what if these patients are those that have hypocalcemia? Okay, hypocalcemia causes seizures, right? Okay. So what equipment do we need? So here's your picture. So what do you do?
Privacy.
So if I ask you select 5 that apply, what will be your 5?
Oxygen.
Oxygen suction. What else? Loosen clothing.
The bed.
Side rails. How many side rails up? How many are up here? Oh, 3. Okay, 3.
Padded side rail.
Yeah, you pad the side rails, but no padded tongue blades. Okay.
Bed.
Okay, bed in the lowest position. All right, are we clear?
Yes.
All right. Oh, one thing not shown here is we need an IV access.
Yes.
Okay. So that would be your number 5. Are we clear?
Mhm.
Why do we need an IV access?
For the medication.
Okay, because you can't administer any drug to stop the seizure unless you have an IV access. Okay, you cannot, I mean, I'm not saying you can't, but it's dangerous when you attempt to put in an IV access during a seizure. It's too late. Okay, you're gonna have injuries. You either injure the patient or you injure yourself. Okay, you could stick yourself. Okay. So here are just read on the females because this is patient-centered care. This is a QCEN item. So you probably noticed this already in several chapters whenever it says something, a specific gender or specific race, specific age, gerontological conditions, etc. So that's patient-centered care, okay? PCC, that's testable on the NCLEX. So here are a few things, with women. Okay, so that's the data that they have. Okay, especially teenage moms here. They smoke cocaine, for instance, or crack. And here's one for the elderly. Okay. All right, prevention. So if the patient again has any of those bullets we discussed earlier under the seizure section, if we have patients admitted with those conditions that are known to trigger a seizure, then you institute seizure precautions. Do you need a doctor's order for this? Not really, okay? So you don't, but if you, let's say you feel more comfortable with an order, okay, just ask the doctor for one. Won't take long, takes a few seconds to put it. And you put up a sign, okay, so that people, all staff are aware. Management. Now there are the main treatment for seizures, whether it's epilepsy or seizure disorders, is medication. Now, even though let's say you can say, oh, but the patient doesn't have epilepsy. Yes, we know, but since the patient has one or more of those conditions we mentioned that can trigger a seizure, then you institute measures. So not just prevention, but we will expect the doctor to order anti-seizure medications. Okay, yes. Yes, hyponatremia causes cerebral edema, and therefore, yes. So that falls under metabolic conditions. All right. So for what was I saying?
Prevention. Anti-seizure medication.
All right. So of course, obviously, if the patient doesn't have epilepsy, will the anti-seizure medications be long-term?
No.
No, we only put them on while the risk, which are those bullet points we listed earlier as known causes or triggers of a seizure, exists. So if let's say they still have the brain tumor, will the seizure risk disappear after they get discharged? No, because the tumor is still there. That makes sense? All right. So that's what I mean by the duration for how long they'll be on the anti-seizure medication will depend on what does the patient have. If it's epilepsy, how long? For life. If it's a seizure disorder, whenever the suspected cause exists, okay? There are surgical options, but there's nothing really. For instance, I had a nephew, young, good-looking guy. He's now 20 years old, I think. Yeah, he's in college now. Good-looking guy. I mean, Filipino Russian kid, no, tall guy. Well, typical teenager, hates everybody. He had seizures for his first 5 years of life. Okay? He had epilepsy. The mom was just distraught, just going crazy. What then they do? Specialists have seen the child, and then suddenly it just stopped when he turned 6. It stopped, and then everybody celebrated. Oh, finally, yeah. How's Max? Yeah, Max is now seizure free. He has been since 6. He's now 20. Okay.
That's the question.
Yeah.
You mentioned about you only give medication, seizure medication based off of the so if a person comes in with like high fever, you're not gonna give them the
Well, that one's easy because the fever, all you do is control the fever. Yeah.
if you was seizure medication. Yeah.
Yeah, for fever, we don't really have to. I mean, it's common. If the patient has a high fever, that's why we lower the fever because we don't want them having a febrile seizure. All right, medications, it's the key for successful management of a seizure disorder or epilepsy is medication compliance, right? Now, your medication list is oh, never mind. It has side effects now. Okay. So the 15th edition has restored the side effects. The 14th did not. Overall, since the most common medication used for epilepsy are either phenytoin, which is Dilantin, or levetiracetam, which is Keppra. So this is your most common side effect. It causes gingival hyperplasia, which can cause gum bleeding, injury, and pain. So what would be your best teaching for patients taking those drugs? Okay, frequent, good oral hygiene, okay? And always always inspect the oral cavity. Well, like I said, we'll skip the surgical management because, it's available, but it's not really shown to be effective. So the most effective management of seizure disorders, including epilepsy, remains pharmacologic therapy. So we'll skip through that section. Let's go to table 61-5. All right, for the exam, I'm only testing the commonly prescribed medications we see in clinical, and they are the ones I highlighted here. So take time to highlight them on your own. So carbamazepine, clonazepam. We're getting there. Okay? All right, next is gabapentin. And as I mentioned, levetiracetam is frequently used, especially in the hospital. So it comes in IV and pill form. Next are the following: phenobarb, phenytoin, primidone. And we have two more after this: topiramate and valproate. Any questions?
Can you, what's the wait, hold on. Wait,
You gotta be able to see this on the recording, right?
Yes.
yeah, but sometimes it doesn't show up, like when you say you're gonna show something.
But it's showing now.
It's difficult when I have two screens, okay?
Because can you go back down, so before, Galliprix, alright? Before that one? Hold on. Keep going. Keep going. The next one. Okay, thank you.
All right. Okay, so for teaching, the patient again has to understand, make sure the patient understands the duration of the therapy. It has to be realistic. If the patient has epilepsy disorder, then they must understand that this is lifelong. And when they say, oh, but I haven't had a seizure for 10 years, well, that's why you haven't had one, because you've been taking the medication. Now, several conditions, including other medications or disorders, can alter the drug levels. So therefore, if they have a seizure, breakthrough seizures every now and then, that can be caused by those conditions, because certain medications, let's say they're taking over-the-counter medicines or antibiotics, for instance, short-term for an infection, they can alter the drug levels of their medication. So patient must therefore consult with their physician whenever they're taking new medications. Okay, so that they can order to check blood levels of the medications they're taking to make sure they don't get any breakthrough seizures. Let's go to the life-threatening complications. Before that, let's finish this page. There's a teaching here, chart 61-6. So it covers medication compliance. Here, this condition, as with any other chronic illness, if they experience a condition wherein they cannot take anything by mouth, so how are they gonna take their medications now? Yeah. Okay, very good. When they travel, no, they have to make sure they have them in their suitcase. Now, as far as driving, I'll leave it state to state because we don't know. Each state has a different policy on how they handle chronic conditions like this. The Republican states, which are southern states, are more lenient. Okay, they really have very little constraints about driver licenses. So I've lived in the South for 9 years, and yeah, even people who can't see, especially if they're veterans, they're still given driver licenses. Yeah. Takes a lot to take away somebody's license down south. Okay, let's go to the last topic on seizures, which is status epilepticus. So as described already, this is a seizure lasting 5 minutes or longer, or if the patient has a second seizure within 30 minutes of the first one. And of course, if they have more, that's still status epilepticus, okay? So we need to interrupt this therefore. So here's the consequence. This will lead to brain damage and irreversible brain damage. Medication. So there are 2 medications approved to stop the seizure. These are IV diazepam or IV lorazepam. Okay. Now this is only to stop the seizure. After administration of either medication, the seizure will stop. This will always be followed by phenytoin or phenobarbital, or it could also be levetiracetam. All right, because the 2 benzos will only stop the seizure. All right, but will it stop future seizures? No, because remember, status epilepticus can be a seizure lasting 5 minutes or longer, or a second seizure within 30 minutes. So do we wait for the second seizure to happen and then stop it again? No, to make sure it doesn't happen, we give IV phenytoin, phenobarbital, or levetiracetam. Okay, so those are the most common medications used to manage status epilepticus. So it doesn't matter whether the patient is a child or an adult. Okay, so same therapy. Yes, sir.
So you said the person having a seizure, if they have a second seizure, that's when
Within 30 minutes.
Within the 30 minutes?
That's
then-
still status epilepticus.
But you said we don't use the diazepam, we use the pros.
No. Oh. To stop the seizure, because it's status epilepticus, right? To stop it, you use either diazepam or lorazepam. I know it mentions there phosphenitoin. Never seen a hospital use that drug. So it's either diazepam or lorazepam. Now, after that, the patient has to be given an infusion of phenytoin, phenobarbital, or levetiracetam, because can they have another one? Will it be called status epilepticus? Yes. So therefore, do you want it to happen again? No. Okay, since we know the known causes of seizures, so again, institute seizure precautions in those patients. And sometimes the doctor doesn't even wait. Okay, so let's say the patient has certain diagnoses like hemorrhagic stroke or brain tumor. They already order the anti-seizure medications, okay, automatically. They can't afford to, they can't risk the patient having a seizure, right? Because you have the opportunity to prevent one, right? So why not prevent it? Okay? Rather than waiting, let's wait and see. Okay, no, it's dangerous. Okay, seizures are dangerous. That's about it. Any questions on seizures?
And hyperthyroidism,